Hello? Yeah, thank you. Well, thank you very much, all three speakers, for these motivating talks. Now it's time for discussion, questions, and suggestions for the audience, please. Yeah, over there. Helen, please. Yeah, maybe, yeah, approach the microphone, please.
Well, good morning. My name is Helen Morment. I'm from AMMF, the UK's Cholangiocarcinoma charity. And my question or comment really is for Dr. Patel, and thank you so much for such a clear oversight into the coding problems and the data problems that we have and the terminology problems that we have with cholangiocarcinoma. It's certainly long been a passion of ours in the UK that the lack of robust data because of the coding problems is certainly not helping to prove what we actually are seeing day to day, which is an increasing incidence and far more younger people being involved. At the moment, the situation is that's just opinion, that's just anecdote, because without robust data, we have nothing to push forward our request for improved healthcare policy, etc. However, in the UK, we are working very hard, exactly what you're asking for, to improve the situation, and it has been really good to see ICD-11 showing the 3 anatomical sites actually correctly coded instead of what we had in ICD-10, which was the 4 subcodes, which were incredibly confusing, and no perihilar or hilar cholangio. We are actually in touch with the WHO and IARC, and so what I'm actually saying is I'm very happy to tell you what we're doing in the UK, and let's all get together, and the coding will make a huge difference, and the robust data is absolutely what we need. So thank you.
Thank you very much, Helen, for your very important comment. Yeah, I feel it's very important to have a specific coding for perihilar cholangiocarcinoma. This is a very good initiative supported by several groups, and it's a good message that the World Health Organization will include this coding for the future, and this is something that we should use, as was discussed in this panel of experts. So next questions and comments from the audience. Please don't be shy. No? Yeah, great, please.
Yeah, since nobody's stepping up. So the coding is really critical, and even people who attempt to do it, they do it wrong. So I guess my question is, do you think we could use some sort of machine learning with input to have a more rigorous way to code the data that's available in medical records?
So that's an interesting suggestion. One of the limitations there might be the nature of the data that's obtained and collected. So in order to use machine learning, we would need to be certain that we had systematic collection of a series of data sets from individuals with all kinds of cholangiocarcinoma. So I think maybe some of the efforts that Komodo and others are doing might in future allow us that opportunity, but we're not there at this point in time.
Please.
Thank you. John Bridgewater, UCL. Excellent talks. Could you please make a guess as to why we've got this rising incidence of intrahepatic cholangiocarcinoma? It's going against all other trends, and as I understand it, we don't really have an answer for it. I don't mind who goes first. Thank you.
So I'll go first. I think clearly the first thing that comes to mind is this a real increase, and is this something we need to be concerned about? And that would obviously reflect potential changes in risk factor, exposure, etc. over time that's driving that increase. But as I'd alluded to, and I can let Jill comment on this as well, there are other factors that could result in confounding this. So coming back to the issue of perihilar cholangiocarcinoma that I talked about, If there are differences in how those are coded, and a vast majority of them are coded as intrahepatic, as would have been done if they'd used the ICD oncology second version, that could result in a spurious increase in numbers. So I don't think we're at the point that we can really be certain that the trends we are seeing are accurate, unless we have verification that the coding system that was used was identically applied to all the cases. Now, in the future, I think we might get a better idea. In specific populations, for example, in certain age groups that might have a finite time period that you're looking at, you might be able to get a more accurate assessment. But I personally don't know for sure if the incidence is truly increasing.
My question relates to the mapping of the disease and treatment centers. Is there anything in the future that will look at the frequency of cases and in across the board, not just large geographic areas, that might point to and identify perhaps environmental and infrastructure problems that might be leading to an increase in the disease?
Yes, and that's a great question. I think I'm on here. Great question. I think it certainly bear more analysis, and we could certainly construct a regional type of study based on our healthcare map of differences in terms of incidence. It's certainly something we could piece together, and I think that's definitely possible with the data.
Please.
So I'm a patient, but I recognize and understand the need and the tremendous challenges there are to improving the coding. And there's no question it needs to be done, but should we also be trying to push for 100% genomic profiling and creating some kind of a central database where that data becomes available for research and analysis, getting out beyond the anatomical and clinical presentation of the diseases. It just seems like the future is more geared towards the genomic profile of the disease versus where it is and how it presents. And if we could, I understand that this is probably order of magnitude more difficult than fixing the coding, but it seems logical to me to try to focus at least some resources in that area. And I'm curious what you think, or if there's anything currently being done in that space.
Certainly with the fact that genome sequencing has now become so cheap and widespread, one would certainly hope and expect that over time we would start getting more genomic information as well as other types of information that can then populate the kind of data sets that Dr. Gores wants to use for machine learning, leading us to more accurate classifications of these cancers in a global holistic manner. That clearly is a direction I think that we're headed to, not just for cholangiocarcinomas, but for many other diseases as well.
But are there any initiatives underway to make that happen, or is it just a desire and a dream at this point? Or is there some action that we can take for our disease and lead the way?
That to me sounds like a call for action, so perhaps you can take the lead.
Yeah, that's a good comment. Actually, a perfect coding is very important in order to also ascertain the potential risk factors, because obviously if we include perihilar as an intrahepatic or extrahepatic, we will never dissect what are the potential risk factors involved in this coding. So I think it's very important to have some consensus on this. And regarding the potential international working groups, there are a couple of them. We will have a presentation today and a workshop of different working groups where anyone from here can collaborate, include patients, data information, and ideally in the next future we should have not only classification according to the location, also according to genomic information, epigenetic, and this is something where we should move forward. So that's a good comment. Please.
Thank you for the excellent presentations, and I completely agree we need to have this clarity on coding and so that our studies can be accurate and even applying genomic information. It occurred to me, though, as I was listening, that there might be an incentive today for people to call perihylers intrahepatics because of the access to drugs on trials, and you could make the argument that although it's at the hilum, it's invading down, and it's sometimes a very hard call because you don't always have pathology, you just have a biopsy. And I wonder if there's going to be a trend towards overcalling intrahepatic so you can get them sequenced and on a FGFR or an IDH1 or some other type of protocol. It'll be interesting.
If I could just jump in quickly. I actually want to come back to your comment earlier about potential misclassification and how that affects the trends. I agree with you that coding is critical and that we need to better define specific entities so that we can understand better what are the risk factors associated with that. But I do find it interesting that at least in the US, I know it looks a little bit different in Europe, the trends are increasing both for intrahepatic and for extrahepatic, as best as we can define them, which means that even if there is some misclassification of perihilar tumors, we see them going up for cholangiocarcinomas across the board here.
Do you think it's a matter of better diagnosis and awareness, or it's a matter of increasing incidence, or both things together? What do you think about that?
Yeah, I think certainly that both are possible. Increasing awareness can increase the diagnosis. But I think we also do have increasing obesity and other risk factors that may be leading to true increases in risk.
How do you envision this for the next future, since now there is antiviral therapies for hepatitis C, for example, for intrahepatic cholangiocarcinomas? About 5–10% of the cases have associated infection. Now with the new therapies, we are able to almost eliminate in almost all cases. How do you envision this in terms of incidence, and also the fact that the incidence of NAFLD is increasing dramatically, and this is a risk factor for gallstones, and then on cholangiocarcinoma? How do you think, how you could envision this for the future? Any of you, please.
I think you're absolutely right. It'll be really interesting to see what the impact of direct-acting antivirals is, but even 5 to 10% is not a huge percentage. I think NAFLD is a growing problem of concern, and we need to try to understand how these things relate together, which again gets back to the importance of coding so that we know what we're actually looking at as we try to pull together databases that allow us to do this work.
And I think the point that you just made, I think, is a critically important one, particularly with the NESA data showing the increases in extrahepatic cancers in the U.S. population. Certainly does raise some concern that perhaps there might be additional risk factors or changes that have happened over time that are driving those trends.
Yeah, and I think we could also potentially construct a kind of patient journey mapping in a way of other comorbidities and different diagnoses along the journey prior to cholangiocarcinoma diagnosis, and reconstruct that picture of what's happened prior to diagnosis. So it also relates, I think, to the question about the diagnosis driving treatment choices. We can certainly layer on which drugs have been used and which treatment pathways have been followed, and that may also shed some light on why a certain diagnosis was chosen ultimately.
Please.
My name is Roberta Bak, and I'm an RN with 40 years of experience. I am now retired, and I became a patient after I retired. I am from Portland, Oregon, and I have a curiosity, and I keep listening at these presentations for some somewhat morbid data, but the first thing is I haven't heard anything about any studies related to occupations. And I don't know if there's anything coming, but I know in this room there are several nurses who are patients who now have this disease, and it just puzzles me as to what our exposures might have been. The other thing is I've been very active in the Facebook patient group, and the thing that I have noticed that I'm curious about is there data that we could see maybe in a future conference related to time of diagnosis to time of expiration? There seems to be, I think our longest member has 13 years, but it seems like there's a lot of 6-weekers. And how does that time to death relate to age, and diagnosis. And then the other thing I'm wondering is, once someone is stage 4, diagnosed in the stage 4 category, what does that stage 4 time to death look like? It seems like in our group, those who seek aggressive treatment back down, and some are no evidence of disease, and then others are stage 4 and gone. So there's something about urgency and treatments chosen and time to death that's got my brain kind of curious. So that's just all I've been thinking.
So I'll take a stab at trying to answer your first question and let my colleagues try and address the other one. So the strongest link for an occupational exposure and cholangiocarcinoma has been exposure to volatile organic compounds, particularly those that were used in the way this was identified was in a study from Japan, where there were solvents that were being used to clean off printing dyes from printing presses within a closed environment, and many individuals who worked in that environment eventually got cholangiocarcinoma. So it might be of some interest, particularly in the nursing community, to see if there's a clustering, perhaps individuals who might have been exposed to volatile organic compounds, either as gases, anesthesia, things of that sort. I'll let others take a stab at your other questions.
Actually, I want to talk just a little bit about the first one as well. Getting to Paul's data, looking at your regional mapping, which I know you're still working on it, but I found it really interesting. I personally grew up in Kansas. I'm a Midwestern girl, and when I looked at your map, I see little indication of exposures in the Midwestern region, which makes me wonder too exactly about the same thing. Could it be something to do with farming? Could it be pesticides? The problem is that, so I work with individuals who have created huge cohorts to evaluate pesticides and cancer risk. The problem is that these cancers are rare, and so in any given cohort there aren't very many of these cancers, and each pesticide used can have a different effect in a different part of the body. So I think these are important questions, and the mapping that you're doing may give us clues. But we have to think really hard about how to try to specifically look at the exposures that may be relevant and tie it to disease. So let's see, the second question was about age and time to death.
Overall survival in terms of staging at diagnosis and age of diagnosis. Yeah. So, well, in this case, for example, in our case, we will present some data today in the poster session. We have a European database of almost 2,000 patients, and we have completed information from 1,000. We have evaluated this information. It's in the poster session. I will briefly summarize in my presentation the 3 and 5 overall survival according to the staging, so the current presentation, the outcome, the management and outcome of all 3 types of cholangiocarcinoma, intrahepatic, perihilar, and distal. And in the question regarding the age, I think this is very important. There are not, I think, too many studies evaluating that, the outcome and regarding the age. And this is something that we should consider carefully for the future analysis. What do you think about that also?
So yeah. just a word of caution here. The maps that you saw, I think, were very uncannily similar to those that you see for intrahepatic cholangiocarcinoma incidence across the United States. And they really show the lowest is around the Salt Lake City area. And so one might draw the conclusion that perhaps it's something to do with the Cholangiocarcinoma Foundation being here, but we recognize that probably isn't the case. So just a word of caution, just how difficult it can be sometimes, even with this clustering of cases in some areas, to really pinpoint it down to the risk factors that are at play.
Of course, these data give us clues, but it's just a starting point. Then we have to test the hypothesis.
Please.
Hi, I have 2 questions. The first one I think is probably pretty straightforward. I think that I noted that the incidence of ampulla of Vater cancer is increasing, and I know we think of that as a rare disease within the overall categorization of biliary tract cancers, but the the incidence I noticed was 0.6 compared to 1.6 for the more prevalent diseases. So if it's really increasing, maybe we think of that as not such a rare disease anymore. So not such a rare subcategorization. So I wondered if the incidence is really increasing, kind of as a follow-up to the question that Dr. Bridgewater asked. My second question is, can you speak in any way yet to how you think that patient treatment and patient outcomes might be affected as their cholangiocarcinomas are being more accurately or more precisely or more differently categorized according to the plans that have been presented today? Thank you.
So for your first question, ampulovator cancer rates seem to be increasing, but only in the youngest age groups. Overall, when you look by sex and by race ethnicity, they're pretty stable over time, but there's some suggestion that they may be increasing in the younger age groups. However, I will agree with my colleagues that there are always questions about coding and miscoding. And these youngest age groups also have really small numbers. So while we think we see this sort of increase, in fact, those estimates have really large confidence bounds around them. We tend to think that there's an increase there, but it's sort of hard to say if it's real or not.
What's young? You say it's increasing in young.
So in individuals under 45 years of age.
What do you think's driving that?
Well, one hypothesis is that it may be related to obesity, but the truth is we don't really know. We're trying to understand it.
Okay.
Oh, second question. Colleagues?
Well, the most important curative approach is surgical resection, so I think it's very important to improve the diagnosis and the early diagnosis. No? We need to know the risk factors, we need to work on that and try to do some potential screening policies in some particular condition at risk. So I think this is really important. And they are interesting data, as I mentioned in the poster, on data analyzed from a large population in Europe, for example. There are other registries in the world, but the data indicate that the systemic treatments, have a overall survival relative. We don't have data on the treatment linked to mutation yet. We need to see how they work and which is the overall survival related to those. But what it is clear is that an early staging and those patients who go to surgery are those who have really good chances of cure, right? So we need to work on that.
So we're okay right now with our current treatment strategies?
Yeah,
Okay.
yeah, sure. Thank you.
Perfect.
Yeah, I think related to the second question, we have the benefit of kind of a large sweeping perspective on what's happening in the healthcare landscape. And so I think as these initiatives happen, we can certainly monitor progress as to the rates of diagnoses based on all the particular codes, as well as which treatment choices are used. So I mentioned the study that we've been starting with MD Anderson regarding radiation therapy, but we do have the benefit of a large sample size to observe if we're making a difference.
Please.
You mentioned MD Anderson. In your slide of where patients are being treated proportionate to the population, that doesn't take into account all the patients that travel for their treatment. For instance, many do go to MD Anderson and other major cancer centers.
Exactly, that's correct. Yeah, so we tie data to the provider and to the institution level. So we don't necessarily have we don't have patient's home address, for example. That's not something we want, but it's a proxy. Is what we're always kind of working with is a proxy and trying to get the closest representation of what's possible. So.
This is also for you, Paul. If you were speaking to all of us here, patients and caregivers, what is the most immediate benefit of your mapping project, and how can you and how will you get that into our hands?
Sure. Yeah, great question. I think most immediate, with the underlying data, we've worked with the foundation on a couple initiatives like the provider finder, so really highlighting across the nation those providers who are experts in a data-driven manner, so that they don't have to go searching for a provider that's local. I'd say, as we do these partnerships, we're looking to publish and looking to kind of expand our research footprint and really leverage this data to make an impact. So I'd say we're really open to more partnerships and to getting that research out there and published broadly. But I'd say those are two of the key initiatives. We're also, in 2019, we're exploring ideas for a more patient and kind of public-facing service of some kind, potentially similar to the provider finder on a broader scale. We're not there yet, but I'd say those are the few of the ways in which we think it can help the community at large.
Thank you for your nice presentation. My name is Keyshia. I'm an oncologist from Thailand and work on the northern. It's one of the hot areas, if you know. I like your presentation, and I like to share the problems about the coding too, because not just only that the coding is poorly highlighted from extrahepatic, but also intrahepatic, because our limited resource, we don't have. Sometimes we have to admit it that we have to treat patient without biopsy, just imaging and calling with the tumor markers. So many of patients, maybe around 50 to 60%, has no biopsy. So sometimes intrahepatic as coding in the ICD is really intrahepatic or some kind of metastasis. So I think it's really our problems, and I hope that the new coding ICD system would improve in this kind of setting. Thank you.
Do you have any comment? No? Okay, thank you very much for the feedback and for this very nice interactive session. Now there is a time of a break, and then we will continue with a very exciting program. Thank you very much.